Welcome to Adapt NCLEX. Anemia on the NCLEX is usually based on concept. In this video, I'm going to show you how to figure out to recognize which anemia is associated with iron deficiency, B12, folate, hemolytic, and any type of anemia that you need to know. At the end of it, we have 5 select or apply questions to consolidate information. Stick around. This will help you next school and for the NCLEX. Let's go. What are we going to do? We're going to go through each system step by step. First, we got to define anemia. What does that mean? Think about it. Anemia is associated with your red blood cell. So anybody who have anemia means they have low red blood cell. Low red blood cell is due to what? Low hemoglobin. So that's where this is coming from. If you have low hemoglobin, you are going to have low oxygen carrying capacity of your blood. And therefore, this is a major problem. Simple definition of anemia is due to low oxygen carrying capacity, and you have low hemoglobin associated with low RBC. There's specific signs and symptoms for each individual kind, but all of them have one general symptoms associated with anemia. First, let's classify them. How do you classify anemia? That's why we have different types. There's something we call mean corpuscular volume. It's very, very important, and this is how we classify anemia based on how they look and how big or small they are. That's all. And it's called MCV, and that is mean corpuscular volume. How did they calculate it? They base it based on what? The hemoglobin that you have, hematocrit you have in the system, like 45. Then they divide it by blood volume, like 5 liters. And they multiply by 10, then times millions of factors that they can use in the process. They come up with the number 80 to what? 100. You don't need to know how they calculate it. But the NCLEX just know there's a number for 80 to 100. If you are less than that number, what do you think? Less than that number, that means your blood cell is too small. In the process, you call what? Microcytic anemia. If you're greater than 100, that's the top portion of it, your cells are enlarged. Therefore, you have what? Macrocytic anemia. If you are within the same range, 80 to 100, that means you are normal. Therefore, you are normocystic. If you are normal, normocystic. That's all. And now let's take care of each of them and figure out what are we going to talk about. So this is the first concept we have to know. Now, the first one we're going to talk about is iron deficiency. What is the problem? They lack iron. That's number one cause of it. But what is the main idea? This is a microcystic disease. Therefore, this is less than, MCV is less than 80. How does that happen? You need iron to make red blood cells. So iron give you what we call heme. Heme end up forming what we call hemoglobin. And hemoglobin cover large portion of your RBC. So if this is your RBC, and then you have hemoglobin covering large amount of it, it will maintain its shape. In these people, this is the red cell, and hemoglobin just covering small, tiny area because they cannot make hemoglobin. In the process, they'll form something we call microcystic anemia because they're very, very small. That's all. This is what leads to microcystic, very small red blood cell. In the process, you become microcystic. How would you know this patient is suffering from iron deficiency anemia? They're going to be hypoxia. They're going to have dyspnea. This is number one, signs and symptoms you will look for. And then they get tired because there's less blood flow. And then the cardiac output will try to compensate, so it increases. In the process, you have tachycardia. They're going to look pale. They have pallor. and they may have some dizziness due to less blood flow as they exert themselves. What is the major cause of iron deficiency and anemia? Low iron. You're not taking enough iron. Sometimes it's because you're bleeding, usually female, during their menses. Heavy bleeding, right? Or if you have an ulcer, chronic loss of anemia. Sometimes if you see somebody with no symptoms, they are iron deficiency anemia, watch for colon cancer. That may be the problem. And so this is where they will trap you. We already talked about the lab work. I said you're going to have low MCV. Your iron level is going to be low. Your RBC is going to be low. Your hematocrit is going to be low. There is another lab work called ferritin. It's going to be low, right? Those are the lab work you should expect that they're going to and give it to you, and you have to figure out. How do you treat them? Well, go and fix the problem. Increase their iron intake. So iron-rich food. And if they are in a hospital, you can give them IV iron. But you got to be careful. Infusion can cause hypersensitivity reaction. That is the NCLEX key point. Safe medication administration. At this point, you got to be careful when you're infusing it. You have to infuse it slow so that it does not cause any problem. That is all you need to know. Iron deficiency anemia. That's all, based on the lab work, signs and symptoms, what you should expect. Okay, microcystic anemia, first one. The second anemia we're going to talk about is due to something we call thalassemia. You see, thalassemia. This is very unique, right? It's hereditary, so you can inherit it from your parents, and usually autosomal. So this recessive, that means both parents has to give it to you. So they both may be carrier and they're giving it to you. It's usually found in Asia or Mediterranean region. So that's very, very unique in this kind of environment. So you may see it in the Mediterranean area, that you can see it most of the time over there. Sometimes in Africa, Southeast Asia, very, very common. It's a little bit complicated, anemia, but I'm going to give you very short information to know. What do you need to know about this type of anemia? The problem is your hemoglobin is made up of something we call alpha and beta chain. There's two alpha and there's two beta. If any of these is affected, if they have one alpha or one beta, there's different combination. You can see you can have 4 types of thalassemia. You don't have to worry too much. It's because there's two alpha and two beta. It does not matter. Just know if you are in nursing school, they care about knowing that there's something called thalassemia. And what is responsible for is, this is very, very important. They make the cell not to look normal. And they undergo similar thing that you see in iron deficiency anemia. They may undergo like hemolysis, they can break. And if you lack in one of them, you develop thalassemia. That's all. What are the signs and symptoms? These cells are abnormal, so they get locked up in the spleen. So they have splenomegaly, so large spleen. They have pale skin associated with anemia, and then poor growth in kids. You may see it in them. They can have bony defect. So those are the most common things you should be aware of. How do you treat this patient? They will need blood transfusion. So blood transfusion is the key. But the most important, you got to replace them. Bone marrow, stem cell. This is the only way you can fix the actual problem. But most of them get transfusion to help with the situation. Very, very important. Someone recessive, both parents in Mediterranean origin. And these are the signs and symptoms you may see in them. Thalassemia. Now, the third anemia we're going to talk about is pernicious. Anemia is very, very interesting. So this is what happened. In your GI tract, you have a stomach here, and you go into the small bowel all the way to your colon, right? Like that. I'm not drawing all of them. So when you eat, there's something we call intrinsic factor, IF, intrinsic factor. This intrinsic factor is responsible for binding to B12, right? B12, which is the major what? Deficiency in pernicious anemia, the constituent that is needed for the function, right? So B12 bind to intrinsic factor, you go through your small bowel. When you get to the terminal ileum, what happens? You absorb B12 into your blood, and this is how we get B12. And the intrinsic factor get recycled and go back into the your GI tract. What is the problem? In pernicious anemia, this is an autoimmune disease. So they make their antibodies that destroy intrinsic factor, the IF. So they don't have IF. So there's no IF to bind to what? B12. Therefore, you cannot absorb B12. This is the pathophysiology of pernicious anemia. Lack of what? Intrinsic factor. In the praxis, which is what? Intrinsic factor. In the process, what you cannot absorb vitamin B12, and then you have these anemia associated with that. Very, very important. Why do they look macrocystic? So this is one of them where MCV is greater than 100. What is the problem? The B12 is responsible for condensation. So it condenses, right? It condenses the DNA. This is responsible for DNA synthesis, and it's supposed to condense and reduce your DNA size. If you don't have reduction and condensation of the DNA, your red blood cell become huge. So you have what? Macrocystic what? Anemia, MCV greater than 100. What is the NCLEX going to ask you? Signs and symptoms. This is key. And I want you to stop the video, write this down. Signs and symptoms. Whenever they ask you B12, think about neuropsych, tingling. You're going to have numbness. So this patient, safety is their key. They're going to fall down. Ataxia, safety, safety, safety. And they may have big tongue that is red, prostatitis, smooth red tongue. But the most important thing I want you to worry about is tingling, numbness, and ataxia, because they're going to fall. And that's the problem. What is the treatment? Don't forget, when you pick in an answer choice, because they have lack of intrinsic factor, even if you give them something by pill, they're not going to absorb it. Therefore, in the process, you have to give the IM injection. And this IM injection has to be for life if it's due to intrinsic factor. They have to know they're going to be doing this for a long time. This is B12 deficiency leading to what? Pernicious anemia due to what? Autoimmune disease. So this is that one I need you to be comfortable with when I give you a question on that. Folate is also needed for DNA condensation. Very, very important. And it's also when you have deficiency of that, it can be a problem. The most important thing causes for this is like diet. You have low folate in your diet. Or people who drink alcoholic may have folate deficiency. Or if you're pregnant, it can also be. And that's why we want pregnant lady to have, because it can cause neurotube defect or more absorption. If you're not absorbing it, that can be a problem. The key thing I want you to know between B12 versus folate is lack of neuro symptoms. So if you want to know, even though they both cause microcystic anemia, there is no neurological symptoms associated with folate. Folate can lead to neurotube defect, but pay attention, no neurological symptoms associated with it. Key, the treatment, let them increase their folate. So green leafy vegetables is very, very good, right? Or fortified cereal can also help with that. The other thing too is citric fruits are very good in folate, and also peanut butter is very good. So when you're teaching pregnant lady to increase their folate, these are the things that you can tell them to help. But remember, no neurological symptoms, and that is the key difference between that one and then B12 deficiency. This is very, very important. Now, What are the other anemias that are over there? We all know sickle cell. Sickle cell is also a different kind of anemia. It causes anemia, but you have to know how this happens. So sickle cell disease. This is also important. It's inherited, right? It's also autosomal recessive. That's how you can inherit. That means both parents should have it. But what is the problem? Our red cells are usually like that, hemoglobin, right? Due to the shape of the hemoglobin and red cells. In the sickle patient, they look like a sickler, like that. And this hemoglobin is made up of different amino acids. You don't have to know too much. But due to there's a defect in if this is the hemoglobin, there's a defect in the amino acid. So it does not assume the normal shape of regular hemoglobin. The problem is if there is less oxygen, hypoxia is number one. This will cause the hemoglobin to turn itself into a sickler shape. In the process, you have a bunch of sickler building up, and that causes something we call vaso-occlusive disease. And this is what caused the problem. Therefore, you can see that the major problem with sickle cell is the cell and assuming what? Sickler shape due to less oxygen. And that clog the vessels and down they get sick. So lack of oxygen causes sickling due to what? Polymerization of the hemoglobin and the red blood cell. And that is the major problem of it. Therefore, if you want to treat this patient, the best thing you can do is to give them oxygen. Oxygen is good. It will prevent sickling of the whole process. Of course, they need pain management. Very, very important. And you got to flush the blockage, the vaso-occlusive disease. They need IV fluid to help with that. They may need something we call hydroxyurea. Hydroxyurea is used to make fetal hemoglobin, and that can give them more hemoglobin to deal with. But your best bet is to give them oxygen and IV fluid. Of course, pain management, most of the time, narcotic to help with it. What is going to happen in this patient? What do you think? They may have what? Splenic infarct, right? Pay attention. They may have very, very important. This can destroy the spleen, right? You can have splenic infarct or prioritization. It can go into the smaller vessels of the penile area, and I call prioritization. They can also have stroke. So these are the things you have to pay attention to with all these little sickling of the cell. This is a big anemia you should be aware of. The next one is, I call it hemolytic anemia. We're destroying the cells more than we're making them. And therefore, this may be due to blood loss, right? You're losing the blood, right? This is the most common. And therefore, your RBC is low. Your oxygen carrying capacity is also going to be low. Basically, that's the key. And the individual has anemia. What do you think is going to happen? If I'm destroying the cells, I'm going to be jaundice because the hemoglobin get breaking down, the heme portion and the bilirubin in the red blood cell get released, and you go to certain areas of the body and it present as jaundice. Your urine will be dark. That's how you can distinguish between this is due to hemolytic anemia. They can have splenomegaly. The spleen can get large spleen due to sequestration, right? That's the thing. So these are some of the things. Why am I giving you these little things? These little things will help you make a diagnosis in the case study. So if I give you a case study and I say patient has jaundice, dark urine in spleen, and you know this is not iron deficiency anemia, this may be we're destroying something, and this is hemolytic anemia. And those are the things you have to pay attention to. You have to monitor for hypoxia and organ damage. The next one is aplastic anemia, but it's not actually anemia. Whenever you hear about aplastic anemia, think about bone marrow. The bone marrow has two cells. Why? We have cells that has myeloid origin. So we have one that has myeloid origin. And then we have some in lymphocytic origin. This is the myeloid ones that will give you platelets. It will give you red blood cell. It will give you white blood cell. These give you lymphocytes, right? When whatever causing the aplastic anemia, it affects the myeloid origin. So mostly, sometimes it's medication. Medication can do that. Even vaccination can do that. So these are little things that can cause all these problems that can lead to even viral infection can give you what? Aplastic anemia. Or you're getting some radiation. Something is affecting the bone marrow. That's all. Whatever is affecting the bone marrow is causing what? Less red cells, less platelet, and less what? Hemoglobin. And therefore, you have low red blood cell, low platelet, and low white cells. What do you think is going to happen? These people who have anemia, these people who have bruising, bleeding issue, petechia due to platelet problem, and these people who have infection. So when you're dealing with them, you got to deal with all of these problems. The best thing is to take away the offending agent. There's things we can give this individual to improve the red blood cell because we've destroyed what? The red blood cell in the bone marrow, especially if you're getting chemotherapy. They need what? Epotin alpha to help them with that. What is the platelet? What do they need? Opraverkin. Opraverkin. This is what is responsible for helping you make platelets. So it's Opraverkin. And then for the white blood cell, the last name, I call them filgrastim. They are the grastin. So whatever we give it to you that has a last name, grastin, filgrastim, is going to help with what? The VBC. This is another form of anemia, but it's not just anemia. It has other things associated with this. So there's a lot of teaching associated with it. And this is all that you need to know for anemia. So in summary, the best way to answer questions regarding that, if you hear about iron, think about pica or the brutal nail, and you know this is a microcystic anemia. If you B12, think about neurological problem, and this is what? MCV is macro. So this is macro problem. If it's a folate, there is no neurological problem, no neuro issue. If it's aplastic, it's not just what? Red blood cell. This is what we call pancytopenia. You have pancytopenia due to what? Low red cells, low white cells, and low platelets. If it's hemolytic, I want you to think about jaundice because we're destroying your cells. And if it's a sickle, it's due to hypoxia, leading to what? Sickling of the red blood cell and polymerization of it, and that is causing problem. You can have an infarct, and therefore pay attention to that. That's all. Simple way to learn all the anemias associated with that. Therefore, let's do these questions. We're going to apply these questions. Number one, you know this. Which finding should the nurse expect? Stop the video, put your answer in the comment. Answer is yourself. Selected apply. And nurse is assessing the client diagnosed with what? Iron deficiency anemia. Go. The main problem is iron. What should you expect? Root nails, tingling in the hands and feet, fatigue, low mean corpuscular volume, and glossitis with a smooth edge. What do you think? What do you think? I know you know the answer. You put the answer in the comment and let me know. But what? Brittle nails is associated with iron deficiency anemia. This is a neurological problem. You go with B12 associated with pernicious anemia. They're going to have fatigue, and the MCV is going to be low. Glossitis is not associated with this. Is related to what? What do you think? What is classic associated with this problem? This is a B12 deficiency. Therefore, we don't see this. The next question is same. All of them are selected apply. Which assessment finding are consistent with this condition? Selected apply. And this is caring for a client with what? Pernicious anemia. This is a B12 deficiency. What do you expect? Ataxia, decreased intrinsic factor, MCV of 100 or greater than 100, tingling in numbness, and pica. Stop the video, pick your answer. But just by now, you know this pica is associated with iron. This is a neurological problem, that's B12. This is the intrinsic factor associated specifically to pernicious anemia. MCV is greater than 100, excellent. Tingling and the numbness, neurological problem. So 1, 2, 3, 4 are your right answer. This is just to consolidate what you've learned. This is what the NCLEX will ask you. Select or apply. I like them to make you comfortable. You don't have to select everything. Which findings support the diagnosis of what? Folic acid rather than B12. They all causes MCV that is high. Which laboratory results for a client with what? Microcytic anemia. Which one support folic acid? No neurological symptoms. That's all. Absence of neuro symptoms. Excellent. History of alcohol use. Excellent. What do you see? Decrease MCV. MCV is supposed to be large. You see micro here. Yes. Increase MCV. That sound excellent. Glossositis is what? Associated with the B12 deficiency. So 1, 2, and 4 are your right answer. What is your score so far? Number 4, which finding should the nurse anticipate? Select or apply. A nurse is caring for a client diagnosed with aplastic anemia. You know this is pancytopenia. You see frequent infection, petechia, elevated platelet, fatigue, and a decreased white count. This is our concept. Like I said, I'm trying to help you consolidate the information. Your WBC is going to decrease due to aplastic anemia, therefore frequent infection. Your platelet is low, you're going to have petechia. The platelet is not elevated. You're going to have fatigue due to anemia, and your WBC is going to decrease. So the only wrong answer is number 3. How are you doing? Last question. I know you get it. 5 out of 5. Which intervention should the nurse anticipate? Select or apply. A nurse is caring for a client admitted with a sickle cell. We want to prevent sickling as much as possible. And you know the pathophysiology, they get sick because of hypoxia and sickling due to polymerization, blocking vessels, vaso-occlusive disease. Therefore, what do you see? Administer supply oxygen, encourage increased oral or IV fluid, restrict activity to prevent pain, administered opioid analgesic as prescribed, limit fluid intake to prevent fluid overload. What do you think? We cannot limit fluid. I just said it. You need hydration. Oxygen to prevent sickling. You got to increase fluid intake here. So test taking strategy. 2 said increase fluid. 5 said decrease. Therefore, one of them has to be wrong. Whichever you think is right. You don't restrict activity. Let them move and give them opiate. So 1, 2, and 4 are your right answer. These are adapting class. All types of anemia, iron, folate, B12, pernicious anemia, what? Aplastic anemia. And then we talk about thalassemia. Take care of yourself. This is what you need for the NCLEX NSC school. Take care of yourself in this video and help you. Look on the screen. There's more video you can watch and share it with your friends who will be on it. And click on the like button and subscribe for more content like that. Take care of yourself and bye.